thank you for Carissa for having me. I am Dr. Corinne Smorra, but all my clients call me Corinne. I am the Chief Clinical Officer here at Heart and Mind Counseling, and we operate in 18 states. We have several therapists that are familiar with congenital heart disease experientially. Either they have it, they have worked in hospitals for 20 years in the CHD clinic, or someone in their family has it. So that's part of it. I myself have congenital heart disease, and it was the focus of my dissertation for my doctorate was social workers' experiences with congenital heart disease interventions for adults. The primary portion of my practice is working for loved ones and those that are afflicted with congenital heart disease. I'm going to start off here because we're talking about PTSD, which we see a lot of when you are involved with congenital heart disease. And what is it? It's an anxiety disorder due to experiencing a traumatic event. Typically, men are exposed to more trauma than women. However, women are twice as likely to have PTSD. And as we know, children can also develop PTSD. I have a little picture here of PTSD from a PET scan. And we have PTSD with a brain with PTSD and a brain with no PTSD. And when you look at that purple area, it's called the higher McGUR5 receptor availability in an individual with PTSD versus a healthy comparison. And this receptor helps keep our brain system normal functioning. So when you have a lot of the purple, that helps your brain be functioning from a scientific. Now, I'm not going to get too scientific here. This is probably as scientific as I'll get. But you can see the difference when you look at the pictures, how much less of that purple area in your brain is. And like I said, that purple area helps your brain function in a normal reactive fashion. So what does this have to do with CHD? Well, between the trauma of the surgeries and the interventions, whether it be watching your loved one experience it or experiencing it yourself, there are a lot of opportunities for PTSD to present itself. So what happens? Well, when we take a look, I have this chart here, it's called a window of tolerance. And normally what happens, we all have a window of tolerance. And when I describe the window of tolerance, you can see when something happens, we're used to bouncing around in a window of tolerance. So for example, you spill your water and you're thinking, oh, not a problem, I'll just grab a napkin and clean it up. You're operating in the window of tolerance. But when something happens that bounces you out of that window of tolerance, you're going to go into a hyperarousal or a hypoarousal zone. And those zones are where your PTSD kind of plays around. So hyperarousal is where you're on edge, you're hypervigilant, or hypoarousal is where you're numb and depressed. So your normal experience, if you have a common response to trauma, you're going to bounce out of that window of tolerance, but you'll kind of bounce back in. When you get repeated trauma, your window of tolerance starts closing. So it gets easier to be bounced out of it. So you're in a constant state of hypoarousal or hypoarousal. So the objective when we do therapy to help for PTSD is to get that window of tolerance to open back up so you can safely bounce around.